Hello everyone, welcome back to my channel. I am CPC certified medical coder. Today, this is our day 2 of our surgery coding training. In today's session, I'm going to explain the integumentary system procedures, their guidelines, coding concept in a detailed way. So stay tuned and let's begin. So in the integumentary system, that is an eight procedure we will discuss in detailed way. Integumentary system comes in 10,000 series. Okay, so it will include the skin graft, pilonidal cyst excision, nail procedure, removal of skin tags, excision lesion, incision and drainage, saving, pairing and cuttings, and debridement. So our first uh, topic first is skin graft and ATT, that is an adjacent tissue transfer. So first we will discuss the definition of the skin graft. What is skin graft? As we know that graft means it is a procedure where the skin is taken from the one side, that is a donor side, and placed on the another side, that is a recipient side, where the skin is lost or skin is damaged. Okay, this procedure is done for what purpose? What is the diagnosis? What is the indication? For the trauma, after the excision of tumors, after the infection, and the necrotic tissue removal, for the burn purpose. So, this skin graft is performed because of these diagnostic purposes. Okay, before starting the procedure, to understand the procedure, we have to know the types of skin graft. So, there is three types of skin graft. First, split thickness skin graft, which includes the epidermis, that is an outer layer of the skin, and the part of dermis, that is the true layer of the skin. So, and the second is full thickness skin graft, that is entire skin. Okay, entire dermis and the epidermis. And the third one is the composite graft, that is the skin and the underlying tissue. So, what surgeon does in this procedure? Simply, we have to understand this. First, anesthesia given, and the wound preparation in order to prevent the infection. They will remove the dead tissue, achieve the bleeding control, and surgeon cleans the wound by this way. The wound has been prepared. After wound preparation, the measurement of the defect size is calculated in a scale of centimeter. After that, the harvesting of the graft is done by using a knife or dermatome. It may be the graft, may be the allograft, autograft, or the xenograft. Okay. Now, after harvesting the graft has been prepared, and after preparing the graft has been placed over the recipient side. After placement of the graft, the fixation has been used by using a staple glue or sutures. After fixation, the dressing applied where to the both donor and the recipient site has been covered. The next slide, that is in CPT, is 15100 to 15241 is a skin graft CPT. Okay, and in the ICD, which includes the burns, that is T20 series, and the non-pressure ulcer, diabetes with foot ulcer, skin cancer. So these are the CPT included in the skin graft. I'll show you the books, that is 15100, 5100, 15100 and 151. So here is a surgical preparation of the uh, 15002 is the surgical preparation of the recipient side by excising of the open wound, burn scar, or the incisional release of scar, contracture, trunk, arm, leg, first 100 square centimeters. So it is a surgical preparation. Autograft, allograft is there. These are the codes. So here is a split thickness autograft, and after that we see that full thickness graft, including the direct closure of the donor site, and these are the location including the 20 square centimeter or less. So these are the skin graft. Now after this one we will take the ATT. So what is ATT? ATT is as name written, that is an adjacent tissue transfer. That is a nearby skin is moved, that is a flap to cover the defect and tissue remained attached to blood supply. As we previously seen that flap and graft difference. What is the difference between flap and graft? So flap is a part of tissue that will maintain the blood supply between the donor area and the recipient area. And the graft, uh, there is no attachment, there will no maintain the blood supply. Okay, there is no connection between the recipient and the donor area. So why the ATT is done? So ATT is done because of the cosmetic area uh, trauma defect after lesion removal, when direct closure not possible. Okay, before understanding the ATT, we have to know the types of flap. So there are three type of flap, that is rotational, advancement, and transpositional flap. So rotational flap, it is a semicircular flap, as you can see here. Semicircular flap of skin and the subcute tissue. For the reconstruction, this flap provides the ability to mobilize the large area of the tissue for widen the vascular base. That's why the rotational flap is done. So it is basically a technique. Okay. Now the second one is an advancement flap. Advancement flap, we can say that is a local flap, and the movement is similar, just like a sliding door. Okay. So it moves linearly into the defect without lateral motion, and it is a rectangular in configuration. You can see that, and it is sub-classified as a simple, single pedicle, and bipedicle, and the VY flap. So this one is simply, we can say that it is in a sliding door. It is in a rectangular configuration. So VY flap means we can understand like this is an advancement flap. Coming to next, that is transpositional flap. It is a rectangular, you can see here, or a skin, score skin and the subcutaneous tissue that move about the pivot point into the adjacent defect. Okay, so this is a technique used during the ATT procedures. Okay, why the ATT procedure is done? What a physician will no, what a physician will do in the ATT procedure? Surgeon will identify the defect. After the identification of defect, he will design the adjacent tissue, adjacent skin. After designing the adjacent skin, he will tissue partially cut and move and maintain the blood supply, and the suture has been applied in order to prevent the infection. So in the ATT, the common ICDs are the skin cancer, open wound, scar revision, ulcer, and the CPT are 14000, 1430302. These are the CPT. Important note, that is in ATT, we have to understand that excision procedure. What is excision? Excision is a removal of the entire tissue. Okay, entire part of the body, that is an excision. So in the ATT, as we know that the adjacent tissue transfer, already the tissue has been transferred. Already there is an excision included in this procedure. So while coding the ATT and excision, we should not code excision code along with the ATT separately, because it is already included. If we code that, then we will got then bundling procedure. Bundling will be got. Okay, we'll got the bundling. So we'll not code the excision. Okay, in the ATT. But what if I can say that if a skin in the skin graft, can we code excision or not? It is based on the documentation. Sometime documentation say we have to code both. Sometime documentation say we do not have to code. So when skin graft and excision should be coded? The skin graft and the excision is coded when there is a done in the same site. There is a different site. When we code a skin graft and excision, when the site is different. And if the excision is done on the same site and skin graft, then no need to code the excision procedure along with the skin graft. So here we can understand that skin graft can be coded with excision, yes or no, both, depending upon the documentation. If different site, we can code both. If same site, we should not code. So simple. Now ATT, for ATT coding, for ATT proper coding, we have to understand the primary defect and secondary defect, because there is an adjacent tissue transfer from the donor area to the recipient area. That's why there will be a two defect. What were the two defects? The primary defect and the secondary defect. So the primary defect, the original area that needs repair, it means the recipient site. Okay, the recipient site that needs repair, that is an original site. So we say that the primary defect is an recipient site. Okay, now secondary defect. Secondary defect is an donor site, because how we know that the secondary defect is there? If there is a new wound created by the surgeon to get the healthy tissue for repair, that we can say that it is a secondary defect. So recipient site is a primary defect and the donor site is a secondary defect. No matter the donor site will be the same person or the different person or the different species. So that one is the secondary defect. So that to for coding the primary defect and secondary defect proper, we have to calculate these defect. We have to calculate the primary defect area and the secondary defect area. We have to add these two. How we add this? So take example. I'll give example. Here example written that primary defect, a surgeon removes a lesion from a back, leaving a wound that is an 2 centimeter into 2 centimeter. And the secondary defect, to close this defect, the surgeon cuts a flap from the sides measuring the 4 centimeter into 4 centimeter. So there is a primary defect area. We have to calculate the area, that is an 2. What is an a formula of area? Length into breadth. So we'll calculate length into breadth. 2 into 2 is equal to 4 square centimeter. And this secondary defect area, 4 into 4, 16 square centimeter. So after calculating the area of the primary and secondary defect, we have to add this primary defect area and the secondary defect area. So the total how much? 4 plus 16 is equal to 20 square centimeter. So this is the area, total defect size. Okay. Now in the ATT, we have to calculate the primary defect and the secondary defect, because there is a connection between the primary site and the primary and that is recipient area and the donor area. There is a connection. So we'll calculate both defect. But in the skin graft, there is no connection between the recipient area and the donor area. That's why we have to only calculate the size of the primary site, that is recipient area. For example, burn wound is 6 into 5 centimeter, wound is debrided and split thickness skin graft is applied. As here, the burn wound area that is in 30 square centimeter. So there is a skin graft and the debridement has been done, that is in wound preparation, that is in surgical preparation has been done because wound has been debrided. So we have to code two codes, that is the skin graft code, that is 15100, and the surgical preparation code 15002. Okay. How we know that surgical preparation is done? By knowing the debridement, necrotic tissue excised, and the wound bed prepared, and the excisional debridement, sharp debridement, non-viable tissue removed. So I will show you one OP note of the skin graft. This is an OP note from the Google. I have taken empty samples. Here's a description of the split thickness skin graft, total area approximately 15 into 18 centimeter on the right leg and the 15 into 15 centimeter on the left leg. Diagnosis is stachys ulcer of the lower extremity. And what is the operation? Split thickness skin graft has been done having the total area of the right leg and the left leg has been given. So, indication, 84-year-old female presented recently with a large ulcer on the lower extremity. These were representing order of the 50% more circumference and her lower leg. They wanted to be distribution, guarantee and schedule for the surgery. In the findings, large ulcer of the lower extremity described above. Ultimate skin grafting was quite satisfactory. There are no evidence of infection. In the procedure, that is, when a patient was prepped, anesthesia given, and the wound has been like adequate hemostasis, and there was a minimal fibrous debris needed to be removed. And from the right thigh, the skin was harvested and positioned on the wound, and the mesh gauze was stapled in the position of in a solution, and the C was the dressed. Additional curves followed were at the same time that would not pressure the heel in the satisfactory condition. So here, what is done? Skin graft in the lower extremity and the split extremity in the ulcer and the legs. So first we have to know what is the diagnosis. Diagnosis in the findings there is only large ulcer on the lower extremity and the diagnosis is stachys ulcer of the lower extremity. So we will see the ICD and the CPT. So ICD and CPT will calculate. ICD ulcer, stachys ulcer, stachys ulcer without varicose vein. Do not wish to venous insufficiency with will not code, do not wish to code. Okay, back to lower extremity is there, na? So lower extremity other specified will take because lateral it is not there and specified, not wish to code more. So this is an ICD for the stachys. Okay. Now coming to CPT, that is on split thickness skin graft. Split thickness skin graft. So the split thickness skin graft Lower extremity leg. So here is the main thing, how we take the measurement. So I will show you the measurement. There is a left leg and right leg. Okay. So in the 15100. Okay, so it is a split thickness skin graft of the leg. First 100 square centimeter. So leg is included. That is right and leg. So both leg is there. So we have to add that. Okay, and there is an additional 100. So first that is an 15. Take the calculator. I'll show you how to calculate. So for the right leg, how much is there? 15 into 15. 15 into 15 equal to 225. Okay, learn it. 225 plus 15 into 80 for the left leg, or the 15 into 18. How much? Oh, sorry. 15 into, wait, 15 into 15. How much we get? 225. Okay. Now 15 into 18. How much? 270. So 270 plus 225. How much? 495. So uh, total size is 495. Okay. Total area is 495. So how we take that 495? Let's see. 495. So we will divide. Okay, we will divide. How we will divide? Wait. So there is an 495. 495. Sorry. 495. Mouse is not working. Okay. So 495 is there. So first 100, we will take this code, this one unit, that is in 15100. Okay. For the next 395, how much we will take that? For the first 395, for the 300 we will take this, and the remain 95 we also take that code. Why remain 95? And we will say that 100 square centimeter, and there is a 95, we also take that one, because there is a part thereof is written. So part thereof means the remain part we also have to take the additional procedure. So how many unit we have to take that? 4 unit of this and this one. So come to, so we have to take 5 unit. Okay. So this one. So this one is a split thickness of the leg. First 100, second, third, 395 for that one. So 495 will take that. Okay. So this is an navigation of the 3M. So this way we'll calculate the skin graft. Okay. Now coming to next, pilonidal cyst excision. The second topic, that is pilonidal cyst excision. So what is pilonidal cyst? Where it is present? It is present near the tailbone. It is basically a chronic condition. Cyst happen in the near the tailbone or the buttock side. Okay. So cyst which contains the dirt and hair. So it is caused by some poor hygiene, some infection or sweatening. So there is sometimes symptoms like sinus open, pus discharge, and pilonidal abscess, pilonidal sinus, and painful swelling will be there. So this cyst happen in the tailbone. So this cyst has to be excised. So it is a surgical procedure where the cyst and sinus are completely removed. So in the physician what will do? He will give the anesthesia, make the incision over the cyst and remove the cyst and sinus tract, and either leave open or close with the suture flap. So there are three CPT for the excision of the cyst, that is in 11770, that is in simple excision, where the only wound suture in single layer, or we can say that there is no packing. No packing means wound will be leave open without closing, without bandaging. Okay, so that one is simple excision. Second one, 11771, that is an extensive excision. That is a cyst is extended superficial to fascia, and physician sutures in more than one layer closer. Several layers will be there. In the complicated, that is in 11772, some flap or closer, VY plasty or ZY plasty has been used. By this way, we will know the complication, we will know which type of excision is there. So there the ICD, that is in pilonidal cyst with abscess, pilonidal cyst with sinus. We will simply in the 3M we will navigate how we get that pilonidal cyst without abscess. We will simply get in the 3M. Okay, cyst, cyst. So here spell we will spell pilonidal cyst, pilonidal with abscess, malignant and other specified. Other specified means without infection, without abscess. So the without absent pilonidal cyst ICD is L0571. So this one is the ICD of the pilonidal cyst. Okay, now the third one, that is a nail procedure. That is on 11719 and 11765. Sometimes nails procedure comes in the podiatry system because it is related to the nail procedure, foot procedures. And so it is a minor surgical procedure which is performed on the nails for treating the condition like the ingrown nails, infection, trauma. So here we can see that the anatomy of the nails. What is the nail bed? Free edges are there. This is a nail plate. This is a white portion part which is in semicircular way. That is an lunula. Below the lunula there is a cuticle. There is a matrix mental is there. In the side view also we can see that here is a nail matrix, nail root, nail bed. In the nail bed, upper the nail bed, that's the body of the nail. There's an free edges of the nail. So this is the anatomical view. Okay. So these are the screenshot of the nails procedure, that is a trimming of the non-dystrophic nail, debridement of the nails, avulsion of the nail plate, partial or maybe complete, having each additional evacuation, excision of the nail and nail matrix. We'll see one by one. Here's the biopsy of the nail unit, repair of the nail bed, and the reconstruction, 11765 wedge excision of the skin of the nail. Okay. Now, so first that is an 11719. What is trimming of the nail? Why the trimming of the nail is required? Because of the ingrown nail. What is ingrown nail? You can here see in the picture, that is the corner edges of the nails. It is an toe, but sometimes it's in the fingernail also. Sometimes the corner edges of the nails grown inside the skin of the toe or finger that cause swelling, infection, so that physician will trim that nail. So for that purpose, trimming of nail is performed. But this trimming of nail is performed for the non-dystrophic nail. So what is non-dystrophic nail? Non-dystrophic means that is a thickening of the nail, thickening of the nail not because of the underlying condition. It is due to the aging, sometimes due to the cosmetic purpose also. This trimming of nail has been done. Okay. Next one, that is the debridement of nail code, that is on 11720 and 11721. As you can here see in the picture, that is an which type of disease is there? What is the diagnosis? So this is an onychomycosis. So onychomycosis, or we can say that the tinea unguium, their code is B35.1 and ICD code is B35.1, and this is happening due to the fungal infection of the nail, cause the thickening of the nail, bitting of the nail, and this is due to the poor foot hygiene, wear the tight shoe. Okay, and so physician will debride that toenail or fingernail of the exposed undersides and the tops, and cleaning will be performed using some abrasive material, some chemical solutions, tools, and nail will be shortened and saved, and the code may be vary in number. So 111,720 for the for example, if there is an debridement of nail performed in the toe only, so toe only one in number. So between 1 to 5 we'll give that code 11720. If there is an 11721, there is a more than 6 number in 5 all nails are affected. So more than this 11721 we'll give that. Okay. So coming to next, that is an avulsion. So what is avulsion? This one is avulsion. Avulsion means removal of the nail plate from the nail bed. As I saw now, there is an inside there is a nail bed and upper side is a nail plate. So using the nail elevator or season, physician will remove the nail plate. And evacuation of the sublingual hematoma. Why evacuation of sublingual hematoma? Because of the blood collection under the nail. So the physician will evacuate that one. Physician created some small hole in the nail plate using the needle and the blade and heated needle, and blood is drained out or evacuated. Nail is not removing, only draining. Okay. In the evacuation of sublingual hematoma, there is no removal of nail. There is only the needle has been used and the removing the drain. Only drain is there. Draining purpose is there. Now coming 11750. Physician removes all part of the fingernail or toenail, including the nail plate matrix permanently. Okay, nail. So we'll see that the matrixectomy procedure, and nail plate dissected and lifted away from the nail bed, and the nail plate detached from the matrix using the scalpel, and matrix destroyed using the CO2 laser chemical ablation, or wound is dressed loosely. Now the next one 11755, nail part has been taken for the sample or the diagnostic purpose. Physician uses scalpel or some clipper. 11760, repairing the damaged nail bed. Okay, so I will give you a example of the operative report, that is a nail procedure. Okay, so here you can see the one operative report as an example. What is an ingrown toenail with matrixectomy? So here operative report, that is an preoperative ingrown toenail with infection, right grade toe. And procedure performed nail avulsion partially with the chemical metrectomy, and indication presented with pain, swelling, recurrent infection with right great toenail. Conservative management failed. That's why he came to the surgeon for the removing that avulsion and the metrectomy procedure. Anesthesia given, patient placed in supine, and the right great toe was scraped and wrapped. A digital block was administered. Tourniquet applied at the base of the toe, and the large portion nail plate was carefully separated, removed the using nail elevator and hemostat, and nail matrix to prevent the phenol was applied to the nail matrix to prevent regrowth. The area was irrigated with saline and the hemostasis was achieved. Sterile dressing was applied. So, ingrown nail ages with surrounding inflamed tissue, mild pleurent discharge. Okay, so we will check what is the ICD and CPT. Okay, so here what is done? Partial nail avulsion with matrixectomy. Okay, so ingrown toenail, ingrown toenail, ingrowing nails, other ingrown toenail. Next, what is done here? The nail plate was separated and nail matrix, chemical matrixectomy is done. So, we'll give the matrixectomy code. First, avulsion, avulsion, great toe, and the matrixectomy. Removal of matrix. Okay, nail matrix, nail bed, nail matrix excision, partial or complete, then specified. So, if the nail matrix is there and the avulsion, we will give only this comprehensive code because this avulsion code is included in this comprehensive code. Okay. So we'll give this ingrown toenail L600 and 11750. Okay. So this is an OP report of the nail procedure. Coming to next procedure, removal of skin tag. So here you can see in this picture what is skin tag. Okay. So skin tag is simply a soft, small, non-cancerous growth in the skin that appear usually in the skin where rubbed together due to the friction. It will occur like armpit area, neck area, eyelid area. Okay. So for the cosmetic reason, pain due to friction, irrigation removal is done by the physician. So based on the size and location, doctor may excise, burn, frozen by frozen or using liquid nitrogen ligation. Physician will remove the skin tag. So physician will first clean the area, give the local anesthesia, and tag is removed. Bleeding has been controlled and dressing applied in order to prevent the infection. So there is on two codes. There is on one code that is on 11200 for the removal of the skin tag up to 15 lesion and 11201 for the each additional 10 lesion. For the cosmetic purpose, we will give the ICD Z411 and skin tag L91.8. Excision lesion. So removal of skin tag, we have seen that. Okay. If there is any skin tag OP. Okay. So this is an skin tag. There is an preoperative diagnosis, that is a multiple skin tag over the neck causing the irritation, and the excision of the multiple skin tag, snip excision, and electrocautery heat has been used. Okay. So indication is partially complaint to irritation and discomfort, cosmetic concerns due to the multiple skin tag on the neck area. So the multiple skin tag due to the cosmetic procedure, we will give the ICD Z411. Okay. And the procedure is what one? That is a procedure patient placed in the sitting position. Neck area was cleaned and prepped in sterile fashion. Local anesthesia was administered. Multiple skin tag were identified. Each lesion grasped. Forceps excised based using scissors. Electrocautery used. Wound has been cleaned and dressing applied. So findings, there is an approximately 18 skin tag is there. 18 skin tag is there. Okay. So as we see that, so what is the ICD? ICD skin tag. Skin tag. Skin tag, and some for the cosmetic purpose will give the Z411. Why will give that? Because of the cosmetic purpose will give that code. And there is an 18 skin tag removal, so we'll give that removal of this skin tag in, oh sorry, back skin tag, other specified. So there's an 18. If we see the ICD codes, like if we give the 18, so double one, two codes are there now, so we'll give that 2. Okay, number of lesion 18. So first 10 lesion, first 15 and then 10 lesion. So and we'll add the one more, 11201, 11201, because of 18 tag, 15 lesion is there and then 10 lesion and the part thereof. So remain part we can also take if there is part thereof, the written is there. Okay. Coming to next slide, that is an after removal of skin tag, excision lesion. So excision lesion, what do you mean by excision lesion? So it is a procedure in which physician will remove the skin growth completely along with the surrounding margins. It is done for the suspicious of the cancer, irritation, cosmetic reasons sometimes. So then the excision lesion, physician will clean the area, give the local anesthesia, incision will made around the lesion and the lesion is completely removed. Bleeding has been controlled and the specimen sometimes for the check purpose, the specimen sent to the pathology lab and the wound closure and suture has been applied. For coding the excision lesion, there is some checkpoint. What are these checkpoints? We have to check the level of the skin, whether it is epidermis, dermis, skin lesion, superficial, intradermal, Skin tag what? So these are the skin level. Okay. Next, that is an checkpoint is type of excision, that is in benign and the malignant. As we know that if there is a muscle or fascia level, we should not code the excision lesion in the integumentary system. It will come to the that is in musculoskeletal. We will see that in the next. So checkpoint are the skin level. Skin level, that is an epidermis, dermis, superficial. And the second one, types of excision, benign or malignant. Location of the lesion, size of the lesion. So once the lesion is excised means repair and closure of the wound must be done. So in the excision lesion, simple repair is already involved. So no need to code the simple repair with the excision lesion. But intermediate and complex repair we can code along with the excision lesion in the integumentary system. Now, calculation of the size of the lesion. So, highest diameter plus the multiplying the margin with 2. So, example lesion is 2 centimeter, margin is 0.25. So, size calculation 2 and the plus 2 into 0.5. So, it will come 3 centimeter. Okay. So, this is an excision lesion. Now, excision lesion, I'll show you one example. Here it is. Excision lesion operative report. So here it is an pre-operative report or operative report of the skin lesion and the excision, that is a benign lesion. So which type of lesion is there, whether it is benign or malignant? So it is already written that is benign lesion. It is a pre-operative and post-operative diagnosis, same as post-operative. We will take that only. Okay? Sorry. Procedure performed, that is an excision of benign skin lesion with margin. Indication is patient presented with pigmented lesion on the left forearm, increasing size with occasional irritation. Now, anesthesia is local anesthesia given. Patient placed in supine position. Left forearm prepped and wrapped. Lesion was 1.5 centimeter, margin 0.25. So, the elliptical lesion made lesion completely excised along with the margins. The wound is closed with the simple suture. So, here the lesion size is there and the margin. So, as we know that 1.5 into 1.5 plus margin multiplied by 2. So, lesion size excised and lesion size will get the 2 centimeter and the benign lesion is that one. So, we'll take the ICD in the 3M lesion, um, skin lesion, nevus. It is in the forearm, na? Left forearm, okay. Forearm, left forearm. No. So this one is an Benign lesion of skin nevus left forearm. Okay. Now coming to the excision. Exci- uh, Excision of the lesion skin level to back skin level is there. Skin, skin lesion of the which one? Benign skin lesion of the forearm. Okay, it is in forearm. So it will hand, arms, exclude hands. Benign is there. So size is how much size we get? How much size we get that after calculating? 2. So 2 centimeter will come in this one. It is an simple. So no need to code that. Okay. So 11402 is an code and the ICD D2262. Okay. So now coming to next after the season lesion. In season and drainage. So season lesion done, in season and drainage. So what is in season and drainage? Drainage is in season and drainage is a procedure where the diagnostic is abscess, fluid formation is there. So it will be incise and draining the fluid. So it will there is an two codes, that is an simple incision and drainage and the complicated incision and drainage. Okay, so in the simple there will be no packing. The wound has been open as it is, and in the complicated there is an wound which is enclosed using and some material gauze and some layers has been used and multiple. So here is in code you can see that 11060 incision and drainage of abscess. Example, if in the OP carbuncle, hidradenitis, cutaneous or subcutaneous abscess, cyst fornicle, or parinochia. Okay, so simple or the single. So if there is a single cyst, then we'll some consider that as a simple, and complicated means complicated and the multiple. It means packing has been done. Okay. Now coming to diagnosis, if the lesion is there like an area of abnormal tissue. Okay. Procedure, destruction of skin lesion. So checkpoint, what are the checkpoint for these? So we have to check the types of lesion, whether it is benign lesion, cutaneous, vascular proliferative, or malignant or pre-malignant. So CPT is 17110 and 7250 to 17286. I will show you in the book 17000. 17 become 17000. 7. Okay. For we have to check whether it is a benign or pre-malignant lesion. We have to check whether it is a uh, cutaneous vascular proliferative lesion, whether it is an skin tag or whether it is a malignant lesion. So we have to check this. Okay, we have to check this which type of lesion is there. Based on this, we have to give the destruction procedure. Okay, for example, doctor destroyed 4 pre-malignant lesion, that is an actinic keratosis, using laser. So what is an ICD and CPT? So ICD will be L570 for the actinous keratosis. I will show you. So the ICD is working. Keratosis, actinic keratosis. Do not wish to code. So L570, and the procedure is like destruction of the pre-malignant lesion. Okay, destruction of the pre-malignant lesion in keratosis, actinic. It is in 4. So how we take that it is in 4? We'll take that one that is in 15 or more, and there is an destruction of pre-malignant lesion, first lesion, and there is an second through the 14 lesion, and so 14 lesion there is no part of. So we will take that 4. 4 it means we'll take 4. That is an 1, and there is an 3. So 3 unit of 1700. 3. So we'll take 4. So this one come. Okay. Now coming to next topic, that is an incision and drainage has been done. Last second topic there, saving, pairing, cutting. This is also an skin lesion. Okay. For the skin lesion purpose, this has been done. Reduce the thickness of the skin for biopsies, cosmetic purpose. This one is done. So first, saving. Physician will use the blade, scalpel, to remove the lesion superficially, and superficially means epidermis and part of dermis. No suture will be there. And the diagnosis like skin tag, keratosis is there, nevus is there, and the CPT code depends on the size and location, 11300. How I say that? I will show you in the topic. Here's a skin sort. There is a saving of epidermal or dermal lesion, single lesion. So based on the number of lesion and the location and the diameter. So based on the size of the lesion and based on the location, it is coded. So here is an for the arm, trunk and leg, for the scalp, neck and the hand. So it is an saving. Now pairing and cutting. Pairing and cutting, it is done for the cord and callus. So cord and callus is a thickened area of skin usually in the toes. Okay, what surgeon will do? Surgeon will use the blade to cut, not deep removal, no suture, only remove the hard keratin layer of the skin. So cord and calcitis is a basic diagnosis. plantar warts B07, and CPT code is 11055 and 11056. So this is an pairing or cutting benign. It is done for the benign hyperkeratotic lesion. Example, corn or callus, single lesion. So based on the number of lesion, pairing or cutting is coded. Okay, now last topic, that is an debridement. So debridement means wound cleaning. So the removal of the dead, damaged, necrotic tissue, infected tissue from the wound in order to heal the wound, to prevent from the infection. It is done using instrument, chemical, or even water, that is an irrigation. So debridement coating is something like magical, like it is there is a checkpoint. It is based on the location 11004 to 11006, based on the size, based on the body percentage, and for the fracture, open fracture, there is one based on four type. There is a code for the debridement. We will see that based on the location, like debridement of the skin, subcutaneous tissue, muscle, and fascia of the external genitalia and perineum. And here, the 1105, the abdominal wall with or without facial closure, external genitalia. So these are the locations. So based on the location, these codes are coded. So we have to check that. Now, based on the size, there is an code, that is an debridement of subcutaneous tissue, epidermis and dermis, and first score centimeter. Okay. Second, each additional 20 centimeter. So it is on size, saying the size, muscle or fascia, and the bone level. So based for coding the debridement based on size, we have to check the level of the skin. It means depth of the skin, whether it is subcutaneous tissue, whether it is muscle or fascia, whether it is bone. One thing more, that if there is an subcutaneous tissue in the leg area and the subcutaneous tissue in the hand area, we will not, regardless of that location, we will only consider the depth. We can calculate that depth and we'll code like that. So for example, diagnosis foot ulcer. Okay, procedure debridement of skin, subcutaneous tissue of the muscle level 46 square centimeter. So diagnosis L97509. We simply go in navigation will be simple, like foot ulcer, and how we code. So which one, subcutaneous and muscle level? So muscle level will take na? Muscle level, that is in 46 square centimeter. So first 20, second 20 additional level is there. Second 20 it will come 40, and 6. For the sixth that is remain, that is in part thereof, we will also take that for this additional code. So first 20, and we will take the 2 units of additional procedure add-on code. Okay, that is 11043, 11046 into 2. So this is based on size. Based on percentage of the body, that is debridement of the extensive infected skin up to the 10% of the body surface and the additional 10% of the body and the part thereof. So here is an 11001. So example, debridement of the infected skin 25% of the body surface. So first 10% this code. Second 10% it will come as in 20 this code. And for the 5 remaining also, because of the part thereof, we will take that additional code once more. That is on 2 times 11001. So now, based on the fracture basis, for the open fracture, if any, only debridement is done, that is including the removal of foreign material. Side for the open fracture, open dislocation of the skin subcu muscle fascia, and some one code is there 11012 for the bone level. So based on the, if there is a fracture there and the debridement is done, then we will take this code based on fracture basis. But most important is based on size. We have to understand that. So that, so this is all and whole integumentary topic. So guys, this is an end. In the next session, we will take the musculoskeletal system topics procedures. Please like and subscribe, guys. Thank you.